Hello and welcome to today's presentation. I'm Dr. Jason Noel from the University of Maryland School of Pharmacy. Today we'll be talking about one of the most interesting mental illnesses, in my opinion. It's associated with erratic behavior, can harm relationships, it can cause frustration in patients and family members due to prolonged depression episodes. At the same time, these same individuals can have creativity and outgoing behavior. We're talking about bipolar disorder, and this is a disorder that is very well understood and has lots of, fortunately, very good treatment options if, as healthcare workers, we can get our patients to engage in proper treatment. Here are the learning objectives for today's presentation. At the end of the activity, you'll be able to review the epidemiology, etiology, and pathophysiology of bipolar disorder. You'll be able to describe the current and emerging pharmacologic approaches for the management of bipolar disorder to include efficacy, safety, and roles of available treatments. And you'll be able to review the pharmacist's role in counseling patients on the lifestyle changes, drug treatment strategies, and medication adherence to improve the quality of life and long-term maintenance of patients with bipolar disorder. It's quite instructive to look back at some of the historical perspective on this illness. This has been recognized for many centuries, going back to the ancient Greeks and Romans, who realized and described individuals who had mania and melancholia at different times throughout their lifespans. One of the really interesting findings is that the Romans actually used waters from northern Italian spas to treat euphoric patients. These springs actually was really like a natural source of lithium salts. And of course, we know nowadays that lithium is a key mood stabilizing agent that we use for bipolar disorder. Also, Aristotle, he recognized the creative contributions of these individuals to arts and sciences in that civilization. Moving forward to the 1600s to 1800s, this is where psychiatry began to develop as a discipline within medicine. Bonnet in Switzerland named this illness manico-melancholicus, and Falleret in France identified a circular insanity that was separated by euthymic intervals, like a manic depressive psychosis. So we're beginning to see here that certainly the psychiatric community at the time identified this disorder. In the 1900s, scientists at the time began to recognize and appreciate mental illnesses as having an origin in the brain, and in other words, being a biological illness, much like some of the other physical illnesses we know of and that they've studied at the time. Starting with Emil Kraepelin, who was a noted German psychiatrist of that era. He postulated that a specific pathology was responsible for the various mental illnesses, and each one had their own unique underlying biologic substrate. He coined the term manic depression, which is a term that was used for most of that century. An Australian physician, John Cade, performed animal studies in a mental institution in the 1940s and 50s, which was really remarkable for that time. But interestingly, he found that lithium salts were beneficial for animals in various animal models of mental illness. And moving forward to 1980, where the American Psychiatric Association, through its publication, the Diagnostic and Statistical Manual of Mental Disorders, which at that time was in its third edition, established a criteria for bipolar disorder, which is closely related to the criteria that's still in use today. So the DSM-4, the Diagnostic and Statistical Manual, which is currently now in its fourth edition, establishes bipolar disorder as a mood disorder that is characterized by one or more manic or mixed episodes that occurs throughout the lifespan. Usually, though, there's multiple major depressive disorders that occur on an episodic basis as well. Bipolar disorder is noted for being a chronic and recurrent disorder with shifts in what we call polarity, these mood episodes, that occur over the course of time. So what we'll do is basically describe the various episodes that make up bipolar disorder and then drill down to how those various episodes can describe certain subtypes of the illness. So we'll start with the manic episode, which is defined in the DSM-4 as a period of at least 1 week where patients have a constellation of symptoms that's suggestive of elation, increased energy, and increased risk-taking and goal-directed activities. That period where the manic episode can take place may actually be shorter than a week if the patient's hospitalized. And as you see there, there's a list of various symptoms. Certainly the key component is the elevated, expansive, or irritable mood, with at least 3 of the symptoms listed, such as increased self-esteem, decreased need for sleep, a hyperverbal or pressured speech, flight of ideas, which is a very classic finding. Some people can be very distractible and really unable to kind of focus on a conversation or task. But then others may actually see an increase in focus, an increase in goal-directed activities, and can channel this increase in energy into something more productive. One of the more dangerous signs or symptoms of this disorder is involvement in high-risk pleasurable activities. These can include promiscuous sexual behavior. These can include drug use or breaking the law or shopping sprees, gambling, etc. These things that are really intended to bring additional pleasure to the patient, which often occurs in very poor judgment. So with this, the expectation is that these symptoms cause significant social or occupational disturbances, and that may require hospitalization for the patient's safety. Okay, for the depressive episode, this description is actually going to be quite similar, or actually identical in a lot of ways, to depression that's associated with unipolar major depressive disorder. So very quickly, you basically have a period of at least 2 weeks where the individual has depressed or irritable mood. You notice here that irritability is present in both mania and depression in various presentations, but the symptoms that go along with the depressive episode include depressed mood, diminishment in pleasure in activities that's normally the patient finds pleasurable, change in body weight of at least 5%, which can be an increase or decrease associated with appetite changes, insomnia or hypersomnia. The sleep disturbance here is interesting because in mania, we describe it more as a decreased need for sleep. Objectively, you'll measure that these patients may sleep during the manic episode about 1.5 to 3 hours a night, yet still feel energetic and refreshed in the morning. With depression, regardless of whether it's insomnia, which is a decrease in the number of hours of sleep, or hypersomnia, which is so-called excessive sleep, the end result is the same. The individual is not refreshed in the morning. It's a poor quality, non-restorative sleep, which still leaves the patient low in energy. Psychomotor agitation and retardation can be present as well. A key finding, of course, is fatigue, loss of energy, feelings of guilt or worthlessness, cognitively a decreased ability to concentrate, and suicidal ideation. And again, depressive episodes involve severe distress or psychosocial impairment. An episode that's unique to bipolar disorder is the mixed episode, whereby the patient actually has a distinct period where criteria are literally met for both the manic and major depressive episode for at least a 1-week period on a daily basis. During the mixed episode, it's considered a severe episode where there is significant functional impairment, and as with mania and depression, there can be psychosis, which is a disturbance in reality, such as delusional thinking or auditory hallucinations. The hypomanic episode, basically think of this as a manic episode that is just less severe. Basically, the mood can be elevated, expansive, or irritable. The minimum criteria is a 4-day period. And a lot of the same criteria you'll often see as with the mania, the flight of ideas, the decreased need for sleep, pressured speech. However, the severity is not such that it warrants hospitalization, and there is, by definition, no psychotic features. So with that, you can then begin to define the individual diagnoses, the disorders that the patients have. So a manic episode or a mixed episode in and of itself is not a diagnosis, but within the context of these diagnoses listed here and specifiers, you can drill down to a diagnosis that can be given to a patient. So the DSM-4 currently recognizes a few subtypes of bipolar disorder, starting with bipolar 1 disorder, which in the patient's history can be diagnosed if the patient had at least one manic or mixed episode in their lifespan. Now again, by having a single manic episode, it usually means that at some point in the lifespan they will have one or more depressed episodes, and that would establish bipolarity. However, the diagnosis of bipolar 1 only requires a single manic or mixed episode. Bipolar 2 disorder, by definition, consists of cycling between major depression and hypomania. So the very highest that you can get, so to speak, on a bipolar 2 patient is with hypomania. They do not experience full manic or mixed episodes. However, they will have severe depression. Cyclothymia is a diagnosis which is characterized by fluctuations between low-level mania and partial depression. A specifier for bipolar disorder can be rapid cycling. Rapid cycling basically involves 4 or more distinct episodes of polarity changes in mood, which include mania, hypomania, depression, or mixed episodes, in a period of at least 12 months. So when that cycling occurs very quickly, that specifier of rapid cycling is applicable. As far as seasonal patterns to the illness, you may see a diagnosis with a seasonal pattern, and very often the depression in patients who have a seasonal pattern occur during the fall months as the days get shorter and more, or actually less daylight. Another relevant diagnosis is schizoaffective disorder. Schizoaffective disorder basically involves a chronic underlying psychotic disorder where patients will have multiple mood episodes that are superimposed on top of that. For example, psychosis, which is a disturbance in reality, thought process, and behavior, can actually be quite chronic and persistent with delusional thinking and disorganized speech, etc. However, when these individuals then, on top of that chronic psychosis, begin to have manic episodes, depressed episodes, that may meet criteria for schizoaffective disorder. That is treated primarily as a psychotic illness with the appropriate drugs for the appropriate antipsychotics, as well as the understanding that this often has a worse prognosis than the mood episodes, including bipolar. The causes of bipolar disorder are most likely multifactorial. As far as we know, it's really still not completely well understood. However, we do know, as far as genetics is concerned, that mood disorders will run heavily in families amongst people with bipolar disorders. Mood disorders, either bipolar or major depressive disorder, will be found in up to 90% of patients who have bipolar disorder, and there are specific chromosomal linkages that's been identified whereby both mood disorders and psychotic disorders can cluster in families. Various perinatal trauma, also head traumas during childhood and adulthood. Psychosocial stressors have been known to trigger acute episodes in patients with the predisposition to bipolar disorder. We'll talk a little bit later on about the various neurotransmitter second messenger system abnormalities as well. And there is also a kindling hypothesis here whereby it's thought that recurrent episodes of mood changes in bipolar disorder can sensitize the brain towards future mood episodes. As far as the clinical course of bipolar is concerned, the onset typically occurs late adolescence to early adulthood. You're talking about 18 and up. Very rarely will someone begin to have their first episode of mood symptoms of bipolar disorder after they turn 35 to 40. So really we're looking at childhood onset, young adult onset, so to speak. There can be a long period of time where the patient is really undiagnosed. It's unknown that they have this illness. They may have various mood episodes, hypomania, mania, or even depression. Necessarily know that this is a full-on bipolar disorder, not present for an evaluation, because there really may not be this degree of functional impairment that may show up later in the illness. An individual episode, mood episode in bipolar disorder can last a few weeks to several months. In the case of depression, the average depressive episode, especially in untreated cases, can be up to 4 to 5 months, whereas in a manic episode, you're looking at a much shorter period of time, several weeks, 3 to 4 weeks. And when you look at the entire lifespan, the tendency is to spend more time in the depressed state as opposed to the manic state. The time spent in depression is going to be determined by the number of depressive episodes and the length of each individual episode. And those actually tend to be somewhat greater for depression compared to mania. Again, it's important to remember that this is a chronic and recurrent disorder. It's been noted that over 80% of patients have had more than 4 episodes in their lifespan. Depression can, when you look at the cycling and the longitudinal course, depression often precedes or follows a manic episode, very often with no intervening period where the patient's euthymic. So that can be very dangerous, coming from the very highs of a manic episode into the depths of depression. Can be very problematic, especially when it relates to suicidal ideation. Cycle frequency tends to become increased as the patient goes on, especially when they are not receiving appropriate treatment. The cycles tend to occur more frequently, tend to become harder to treat, so that, of course, speaks to the critical importance of getting these patients on a adequate maintenance therapy and preventing acute episodes. There's a high rate of substance use disorders amongst patients with bipolar disorder, and there is a higher mortality by a factor of 2 to 3 primarily because of suicide and as well behavioral issues that are poor judgment, risky behaviors that can lead the patient to bad outcomes. As far as epidemiology, it's thought that the prevalence of bipolar disorder can be as high as 4%. Depending on how broad the definition is in the study that they're looking at. If you limit it to a specific diagnosis, bipolar 1 disorder or bipolar 2 disorders, each of those are thought to have a prevalence of about 1%. But when you do add up all the other kind of subsyndromal forms of bipolar disorder, you begin to approach 4%. No differences between the genders or amongst people of different races and cultural groups. And the only difference gender-wise is that women tend to present with depression as their first episode, whereas men tend to present initially with mania. As far as the pathophysiology is concerned, there is a well-characterized alteration in the various neurotransmitter systems. There seems to be a series of imbalances, really. To limit it to just 1 or 2 neurotransmitters would really be missing the whole story here. What we see during the manic episode is an excess in excitatory catecholamines such as norepinephrine and dopamine. GABA, which is an inhibitory neurotransmitter, seems to be deficient in some cases, or you may actually have excesses in an excitatory transmitter, glutamate. And acetylcholine comes into play because that deficiency can actually facilitate imbalances with norepinephrine. Serotonin is also thought to be heavily involved in this as well. A lot of what goes on, both in the pathophysiology and in the pharmacologic treatment, deals with the second messenger systems. What happens inside the cell after the neurotransmitter stimulates it. These second messengers are really kind of the cutting edge in terms of research into bipolar disorder, and as we understand it, a key target to a lot of our pharmacologic treatments. As far as signal transduction, protein kinase kinase C and cyclic AMP signaling have been found to be altered in bipolar disorder, and again, these may be affected by some of our drug treatments. Disruptions in the circadian rhythm, the day-night rhythms that people will have related to sun exposure and general scheduling of body clock. Those tend to be disrupted in bipolar disorder and may actually contribute to some of the mood symptoms. Again, the kindling theory, whereby poorly controlled illness can lead to more frequent episodes. And certainly the neuroendocrine system may come into play with the HPA axis and the thyroid hormone both being dysregulated. So moving into the treatment of bipolar disorder, the objectives are going to depend on where in the illness the patient is at the time of presentation. If they are acutely manic, obviously what you need to deal with is controlling those manic symptoms, trying to return the patient to a normal level of function, and to control some of the externalizing presentations of mania, the aggression in some cases that can be unsafe, agitation, impulsivity, so that the patient and those in his or her environment can remain safe. If they present acutely with the depressed stage of the illness, again, you're trying to cause a remission of those depressive symptoms, trying to bring those patients back up to their baseline from the diminished level of functioning that's seen in depression. And in the maintenance phase, this is really key. What we want to do is to modify the long-term course of the illness so that patient is not going to be as prone to acute mood episodes, both switching from euthymia to mania or euthymia to depression. So preventing those relapses is going to be key. Reducing subthreshold symptoms. When a patient is hypomanic and they, for example, present to their outpatient psychiatrist, it should be addressed as such, as opposed to waiting for them to become full-blown manic and requiring hospitalization. So if they are kind of teetering, if they look a little brittle, like they may be getting into an acute episode, it may be a good time to looking at the patient's medications. Some of the other maintenance goals: reducing suicide risk, reducing overall cycling frequency and mood instability, trying to improve the patient's overall level of functioning. If able to, for example, return to school, continuously stay at their job, perhaps get a promotion, do things that acute episodes of this illness would more than likely prevent them from being able to do successfully. And finally, the key objective is to promote treatment adherence, and we'll have a bit to say on that later on. Okay, briefly a few points on non-pharmacologic treatment of bipolar disorder. Basically, if you identify psychosocial stress as a trigger to an acute mood episode, one of the therapeutic approaches, of course, would be to try to minimize that, get supports in place so that patient's stress level can be reduced, and addressing some of those issues, some of those other issues such as sleep, nutrition, and exercise that can hopefully promote overall mental health and wellness. Psychoeducation, such as supportive counseling, cognitive behavioral therapy, these things are vital in helping the patient realize and internalize what it is that's going on with their illness, and try to encourage and promote coping strategies so that they're not letting things kind of get blown out of proportion and become difficult to control. Electroconvulsive therapy, or shock therapy, is actually a well-established somatic treatment in psychiatry that has a long record of success, especially in the setting of treatment-resistant depression. And when you look at bipolar disorder, resistant cases of depression or depressive episodes within bipolar disorder may respond quite well to ECT. Light therapy is something that is often used in the geriatric population, with especially those who are institutionalized. However, there can be a role in this therapy when you have individuals with circadian rhythm disturbances. So these are some of the strategies that can address some of those abnormalities that we've discussed as far as bipolar disorder is concerned. So these are our menu, so to speak, as it relates to pharmacologic treatment of bipolar disorder. We have a category of drugs that we consider mood-stabilizing agents. Mood stabilizers, by definition, are agents that can help promote recovery from an acute episode of either mania or depression, and at the same time can be used during the maintenance phase to prevent relapses. These agents include lithium and some of the anticonvulsant drugs, which include VALPROATE, carbamazepine, and lamotrigine. The antipsychotics, as we'll discuss, are quite prominent in the treatment of bipolar disorder, so they're going to have an important role as well. And for less widely used therapies, some of the antidepressants, and there are some other adjunctive agents that may be used in selected patients. So we'll be focusing on FDA-approved treatments for bipolar disorder, starting with the mood-stabilizing drug lithium. Lithium, again, is a salt that's found naturally in nature and has been used, as we discussed earlier, in centuries, but really more systematically studied starting with Cade in the 1940s and 1950s. Lithium works, or we think it works, intracellularly to inhibit signal transduction, dealing with some of the second messenger systems, including G proteins and enzymes such as inositol monophosphatase. It is used in the acute treatment of mania and hypomania, but can also be used acutely for depression in bipolar disorder, and can be used in the maintenance phase to maintain a state of euthymia. And as you see, it's available in numerous dosage forms, including regular release capsules, slow release capsules and tablets, and a oral syrup. Lithium is notable for having fairly linear kinetics, but the key issue with lithium as far as the PK parameters is that it's pretty much a drug that's distributed throughout your body water and relies almost exclusively on your kidneys to eliminate it from the body. There is obviously no metabolism step, as lithium is simply a salt that dissociates into lithium and the anion in the circulation. It is dosed really to target a narrow range as far as a serum lithium level is concerned. Again, the renal function of the patient is the key determinant of how much of the drug gets retained in the body, and therefore what the elimination half-life is. But typically we think of those with healthy kidneys will have a half-life in about the 20-hour range. What you will see is that based on the patient's size and renal function, the prescriber will arrive at a approximate starting dose, usually on the low end of the dosage range, and titrating up gradually. Again, we're targeting the serum range anywhere between 0.8 and 1.2 milliequivalents per liter, although some non-responders may benefit from increases in dose up to about 1.5 milliequivalents per liter, but we really try to avoid pushing the dose too highly because there's so many other factors that can go into knocking a high dose into more of a, or high level into a toxic level. The adverse effects of lithium are numerous. They include GI upset, which typically presents with lower GI issues such as diarrhea. That is usually managed well by giving the drug with food or going to more longer extended release formulations if it becomes intolerable. Lithium tremors are described as a rapid adrenergic tremor that occurs with voluntary motion or intention tremors. These can be problematic in that patients who are engaging in fine muscle movements, such as riding or tying shoelaces, may have a hard time doing those activities while the lithium is causing these rapid hand tremors. That is treated in one of a few ways, either by taking whatever dose it is they're on and shortening the interval, giving it more frequently, in other words, or using a beta blocker such as propranolol, because it's thought that the origin of the tremor, at least to some degree, is adrenergic. Central nervous system, lithium is known to have some mild depressive effects on balance, coordination, and cognition. So the thinking there is that this is a CNS depressant agent, and it's a fairly predictable effect in that regard. However, one of the things you have to kind of be aware of, or take with a grain of salt, so to speak, is when patients who are manic begin to complain that they're sleeping more, or they're not as energetic, or not as creative. Okay, certainly you would expect that the central nervous system depressant effects of the drug might come into play, but really think of the fact that they're coming down from a full-blown manic episode, and it may not necessarily be a bad thing when activity levels begin to actually normalize. Other adverse effects: lithium can cause various neurologic issues, again, some of which we discussed as far as the tremor and that sort of thing, but it can progress to more involved motor abnormalities and balance issues, so we have to always be aware of that. And when it does get to where that becomes potentially dangerous, you'll want to consider cutting the dose down. Lithium has almost a unjustified reputation as being damaging to the kidneys. Certainly pre-existing renal disease can really impact our decisions around using lithium as a treatment, and by extension how we go about treating with lithium and titrating, etc. But in people with healthy kidneys and no other insults to them with time, the expectation is that lithium will not, certainly not to the degree as, say, amphotericin B or some of these other really nasty nephrotoxic agents. However, lithium does have a couple of renal effects that are worth mentioning, one of which is a drug-induced diabetes insipidus syndrome, whereby lithium interferes with the kidney's ability to concentrate urine, to kind of reduce the volume into a smaller volume of urine, which will not cause the patient to be dehydrated. What lithium does, again, by interfering with that process, is allowing more fluid to be excreted through the kidneys, therefore reducing the intravascular volume, triggering the thirst reflex, therefore causing the patient to want to drink more fluids as a result of that. So this renal effect of lithium is more of a kind of a dilutional effect in terms of the urine. It's considered to be reversible, and as you will see, that cutting the dose will often help with that diabetes insipidus syndrome. Now, the other part is, well, does lithium cause kind of these irreversible glomerular changes that you may see with, say, amphotericin B? And although there have been some irreversible changes in renal function reported with lithium, certainly not as common, not to the level as you may see with some of these other drugs that have a much better reputation for causing the damage. Another key effect to be aware of with lithium is hypothyroidism. What lithium tends to do is couple the conversion into an active form of the thyroid hormone. So when you have in the thyroid gland the precursors being converted into the active thyroid hormone, that activity tends to be somewhat lowered on lithium. So that is a risk of treatment. One of the things that often happens is when you have a mood disorder and you have low circulating active thyroid, the patient may actually become depressed or show depressive symptoms. So that is a certainly concern to be aware of as well. And some of the other adverse effects tend to be a little bit more benign and self-limiting. The cardiac effects can present as various atrial arrhythmias, and minor EKG changes tend to be benign. Dermatologically, you may see a worsening of skin conditions such as acne and psoriasis. You may see some weight gain when people choose to replenish their fluids from fluids loss in diabetes insipidus with a lot of sugary fluid, and you're picking up a lot of calories that way, which is unhealthy. And you may also see a bump in your white blood cell count. Each of those are considered side effects that can be easily managed without necessarily discontinuing therapy. Again, very important to remember with lithium that this is a narrow therapeutic index drug, whereby really right outside the therapeutic range, you begin to get into, which can be very significant, toxicity. At low levels of toxicity with serum concentrations between 1.5 and 2 milliequivalents a liter, you can get depression in the central nervous system, listlessness, GI upset, speech begins to get slurred a little bit. And as you advance towards levels anywhere between 2.5, 3, and in some cases only slightly higher, you can get into severe central nervous system depression and get to a point where you may suffer a fatal overdose. So lithium really should be kept within the appropriate target window so that the risk of overdose is lessened. This is a list of some of the main contraindications to lithium therapy. Some of these kind of just make sense in the context of the various adverse effects and risks that go along with lithium treatment, such as unstable renal function, patients with recent history of MI, or sinus node dysfunction, the ulcerative colitis because of its effects in the large intestine, and the diarrhea that go along with it. Key thing, though, to note is in pregnant patients, where a particular congenital abnormality has been noted called Epstein's anomaly, which is a tricuspid valve issue that's present in the fetuses of women who are exposed to lithium therapy, especially during the critical first trimester where organogenesis is taking place. So lithium is assigned as a category D drug and really shouldn't be used, especially in the first trimester of pregnancy. Monitoring, you will have to fairly regularly draw blood in patients that are on lithium, if not for anything else, to monitor the serum levels of lithium, but as well looking at things such as electrolyte, thyroid function, and CBC. But in addition, you'll want to monitor, of course, the mood symptoms and how the patient is doing in terms of their mood disorder, and looking at some of the other objective parameters, such as body weight, such as how much sleep the patient is getting on a nightly basis. So you're able to assess for both therapeutic and potentially toxic effects of the drug. Our next mood stabilizing agent is VALPROATE. It's a very widely used anticonvulsant as well as a mood stabilizing drug. It is another agent which is thought to involve intracellular second messengers, but certainly as well a key component to the pharmacology is its effects on GABA and glutamate. VALPROATE is a somewhat stronger drug looking at it in the context of acute mania compared to depression. If you want to fairly reliably get someone back to a euthymic state from a manic episode, VALPROATE is great for that. The effect on raising someone from the depressive phase into the euthymic phase on VALPROATE is not going to be as reliable. This agent is available in a number of different dosage forms. The one that's used most frequently are the divalproic sodium, either delayed or extended release dosage forms. The delayed release dosage form is basically designed to be released lower in the GI tract so as not to give you the worst of the GI upset that can occur with this agent. The extended release is just a formulation which provides for once daily dosing. The dosing is as listed here on the slide, and go with either a start low and go slow approach by starting someone on 750 and 1,000 milligrams a day in divided doses. The other strategy would be more of a rapid loading strategy. If you have someone who is acutely manic, for example, in a hospital setting where you're really are trying to induce a fairly fast stabilization, there is a weight-based dosing regimen that you can use, divalproate, 20 milligrams per kilogram a day for the first 5 days. The expectation is at the end of 5 days you are in a good part of the therapeutic range, and you can look at further dosing adjustments from there. The key thing about it, however, is this rapid loading strategy really works best in the setting of acute mania. Patients with depression tend to somaticize a lot of side effects, and that rapid loading strategy might be something that can push patients into tolerability concerns. And our target serum concentration is between 50 and 100 micrograms per mil, but valproate doesn't give you that same narrow therapeutic index as does lithium. So when you exceed 100, up to 125, or even up to 150 mics per mil in some patients can be reasonably well tolerated. Some of the key adverse effects of valproate is listed on this slide, including the GI upset, which is somewhat less common with the divalproate formulation compared to the older valproic acid capsules. As far as central nervous system, again, this is a CNS depressant, so you can get some sedation. Tremor is also a common sign of CNS depression as well. Hepatically, you'll get a bump in the LFTs in some patients, so you have to be aware of that. Hematologically, the key issue in terms of hematologic effects is with a drop in the platelet count. So really that's what we keep an eye on the most with, say, divalproate, more so than the red cells or the white cells. Pancreatitis tends to be a very acute onset, upper quadrant pain sensation you can get, as well as dermatologic skin rash, weight gain, and alopecia, which has been reported with this drug. This is another problematic drug in pregnancy. Valproic acid is designated as a Category D drug, and this is known to cause a whole host of neural tube defects and interference with absorption of folate, which of course is a key vitamin taken during pregnancy to prevent birth defects. So with valproate's influence on that, certainly women who take this during pregnancy really put the fetus at high risk for severe teratogenicity. The age of less than 10 years, younger patients tend to have a higher risk of developing various hepatic compromise with valproate, so your younger patients should be avoiding drug. Okay, the drug interactions, which are fairly common with this, include any drug that can promote bleeding. Aspirin and warfarin, for example. Aspirin, because you're having additive antiplatelet effects. Of course, divalproate, as I just mentioned, can reduce the platelet count. Aspirin can reduce the activity of those platelets, therefore that combination can increase bleeding risk. Combine that with warfarin, you could see as well with warfarin's effects on clotting factors, where you can get an increase in bleeding risk. Valproic acid tends to be an inhibitor of liver enzyme metabolism, so you can get pharmacokinetic interactions as well as protein binding interactions because it's highly protein bound. So when you're combining other anticonvulsants with valproic acid that are liver enzyme substrates or highly protein bound, or even with their CNS depressant effects, you can see where you can get a number of different both kinetic and dynamic drug-drug interactions with this agent. Our next agent is carbamazepine. This is another anticonvulsant, mood stabilizing agent. It's thought to work through sodium and potassium channels, and it works through the GABA system as well. And there is some evidence that it can exert some beneficial effects on the cyclic AMP signaling pathway. Carbamazepine is best utilized for manic episodes and in cases of rapid cycling and mixed episodes. The pharmacokinetics of carbamazepine is very notable for its autoinduction effects. In other words, it induces liver enzymes to actually increase its own clearance from the body, whereby in acute dosing, the elimination half-life is about 33 hours, which then gets shortened to as much as 15 to 25 hours with chronic dosing in someone who has the autoinduction that is kicked in. This is another drug where we do target a therapeutic blood level. In the case of carbamazepine, the range is between 6 and 12 micrograms per milliliter. Some of the common adverse effects include hematologic changes. You can get either modest or actually quite significant drops in your white blood cell count, as well as your all three cell lines, which is what's called aplastic anemia. Various drug rashes have been reported. You can get GI side effects. You can get CNS depression. And the electrolyte issue here is a syndrome of inappropriate antidiuretic hormone, where you get a dilutional hyponatremia. Hyponatremia, of course, can result in some mental status changes, but curiously can also lead to breakthrough seizures. We give carbamazepine thinking that it's an anticonvulsant drug, and one of its side effects, of course, can lead to seizures, so you really need to watch for that. And it is recommended that we monitor the electrolytes on a frequent basis, keeping a close eye on that sodium concentration. Some of the other monitoring parameters, looking at the drug levels, the autoinduction that takes place with carbamazepine occurs over up to about 6 weeks. So really, our final steady state after initial dosing is going to occur after the autoinduction kicks in. And once you do that, you would expect that an increase in the dose, in order to account for the faster clearance of the drug, will need to take place. And once that occurs, you are now dosing carbamazepine in the setting of your increased activity of the liver enzymes. Therefore, that will eventually get you to your final steady state for the drug. Drug interactions of note is, of course, because of its liver-inducing effects, you can get increases in clearance of other drugs that go through the P450 system, including anticonvulsants and some other narrow therapeutic index agents. But as a substrate, it can also be affected by drugs that go through the P450 system as inhibitors, such as erythromycin and cimetidine. A more recently approved anticonvulsant mood stabilizer in bipolar disorders, LAMOTRIGINE. This is a sodium channel antagonist that really seems to have its primary benefit in elevating mood in patients who are acutely depressed or in maintaining mood in patients who are euthymic. This is a mild CNS depressant that is known to cause, in some rare cases, quite a significant dermatologic reaction. The key factor that determines the risk of rash with lamotrigine is actually how quickly it's titrated. So you'll need to really follow the manufacturer's instructions in terms of titrating in order to minimize that risk of the rash. Enzyme inhibitors such as VALPROATE also tends to exacerbate that risk of the rash with lamotrigine. Here we see the available dosage forms. It's lots of convenient oral dosage forms available in the market. And again, the key issue here is the rash. It's not a drug where we worry about a lot of therapeutic blood levels or electrolyte or CBC changes. So really, it's incumbent upon us to ensure that patients are educated as far as why dosage changes are occurring fairly slowly over the course of several weeks. The object is, again, to minimize the risk of the dermatologic rash. And there are various starter packs and other sorts of instructional materials on how patients can initiate this drug safely and titrate it gradually. The maximum doses are going to be dependent on whether the patient's on an inhibiting drug, such as VALPROATE, an inducing drug, such as carbamazepine, or using lamotrigine in monotherapy. The antipsychotics are a important class of drugs as well. They work through a number of mechanisms. Your older first-generation antipsychotics are fairly exclusively dopamine-blocking drugs as far as the therapeutic effects, and you can get some of the other receptors being blocked more for side effects. The second generation antipsychotic drugs, however, are the ones that really have expanded their use and become one of our key groups of drugs that we use in the treatment of bipolar disorder. These second generation or atypical antipsychotics are dopamine and serotonin blockers, and by doing that you may get some beneficial effects on mood and some effects that tend to improve the overall tolerability, especially as it relates to motor symptoms of antipsychotics. This list, which has been growing over the past few years, are the FDA-approved drugs for various stages in bipolar disorder. So olanzapine, risperidone, quetiapine, ziprasidone, dopamine partial agonist, aripiprazole, as well as acenapine and paliperidone are all currently FDA-approved for at least one indication within bipolar disorder. So depending on the drug and depending on clinical status of the patient, the antipsychotics have a number of different roles in bipolar disorder. They can be used in the treatment of manic episodes that are present with or without psychotic symptoms. The antipsychotics can actually be indicated or initiated with a mood stabilizing drug. For example, an existing therapy with lithium may be augmented with an antipsychotic drug in order to get a faster resolution of the acute mania. Lithium is notorious for having a rather slow onset of activity. It requires obviously some titration before you get to a pharmacokinetic steady state, but on top of that, even in a lot of the best cases, lithium's effects occur over time. Antipsychotics, when initiated with lithium or started when lithium is part of a pre-existing regimen, can really help induce remission quite a bit faster than lithium alone. Antipsychotics may actually be a monotherapy. So you think of, say, some of these drugs that have problems in pregnancy, for example, the lithiums and valproate. A lot of these antipsychotic drugs aren't the greatest for pregnancy either, to be honest. Obviously, gestational diabetes is a particular risk that comes to mind because of the metabolic effects of these drugs. However, you might have someone where you feel that the benefits outweigh the risks, and the antipsychotics may be used as a monotherapy in some of these patients where they are contraindicated from using the other mood-stabilizing agents. For agitation, they can be helpful on an intermittent or as-needed basis. A couple of the atypicals have maintenance indications in bipolar disorder, so that can be a potential benefit. And as well, those patients who do have schizoaffective disorder, where the assumption again is that the underlying chronic psychosis is always going to be there, obviously maintenance then becomes imperative with the antipsychotics. As far as bipolar depression is concerned, quetiapine has a FDA approval for treatment of bipolar depression, as well as a fixed dose combination of olanzapine fluoxetine capsules. These agents have been studied and shown to elevate the mood for those who are acutely in bipolar depression. Now, although the adverse effects of the antipsychotics differ from one drug to the next, some of the key effects that are relevant for bipolar patients, especially when being used more as a shorter-term treatment as opposed to a maintenance treatment, you do want to worry about some of these motor effects that can occur because, for whatever reason, bipolar patients may actually be at a slightly increased risk for movement or antipsychotic-induced movement disorder related to those with schizophrenia. So the mood disorder tends to actually increase propensity of the motor side effects. Depressive episodes can, especially with the older first-generation antipsychotics, can actually be worsened by antipsychotic therapy. And the weight gain and metabolic effects associated with these antipsychotic drugs can be compounded when these drugs are being concurrently given with lithium and valproate, which are other drugs that can cause weight gain. Now, in order to really flesh out our treatment decisions, a number of professional associations have developed published treatment guidelines to inform us on what drugs to select for various stages in bipolar disorder. There are published guidelines looking at acute mania, depression, and mixed episodes, and some of them, which we'll discuss, includes the 2005 TIMA guidelines, the Texas implementation of medication algorithms, as well as the 2004 expert consensus, the 2005 American Psychiatric Association, and the 2009 Canadian Network for Mood and Anxiety Treatments. So for acute mania, as you can see, the first-line treatments across the board are going to be lithium, VALPROATE, or SGAs, second-generation antipsychotics. The real key role here, obviously, is with these first-line mood stabilizers getting at least some initial treatment that has some evidence base for taking patients from an acute manic episode back to the euthymic state. And that certainly is the case for the lithium, valproate, and second-generation antipsychotics. The TIMA and the APA guidelines recognize carbamazepine as kind of an alternative for selected patients that can be used. Going down to the second line, as you can see, combination therapy whereby you're adding, for example, an anticonvulsant to lithium or an antipsychotic to either lithium or another anticonvulsant is actually widely accepted. This is a strategy that has been systematically studied, and in fact, the FDA-approved labeling for many of the antipsychotics specifically say that they're helpful for acute mania either in monotherapy or in combination with a mood stabilizer such as lithium or valproate. So these treatment guidelines recognize that, and it is frequently recommended that mania that does not respond to a single drug would be best served by adding a second drug, either another mood stabilizing agent or an antipsychotic. Going down to third line, as you can see, now you're looking at multiple combinations. The APA endorses a switching strategy, switching the second-generation antipsychotic. So you're becoming a little bit less concrete by the time you get to third line, a little bit more variations between the various practice standards, but that is only because the evidence that supports some of these strategies being suggested are lacking. For acute depression, the first-line treatments across the board is going to consist of lamotrigine, and with most of the guidelines, they suggest lithium as well. The lamotrigine plus mood stabilizer regimen is endorsed by the TIMA guidelines. Again, just as a reminder, the lamotrigine, when given with valproate, really represents a fairly dangerous combination, so because of the risk of rash. The second-line treatments, TIMA guideline endorses quetiapine or olanzapine plus fluoxetine combination. Again, both of those being FDA-approved treatments for bipolar depression. And some of the other guidelines look at combinations of drugs. For example, the Canadian guideline actually talks about SSRIs here, plus the APA guidelines and the expert consensus. So the antidepressants really have kind of a checkered history in bipolar disorder. Obviously, if you're not aware, the main risk around antidepressant drugs in bipolar disorder is the risk of switching patients from a depressed state into a manic state, further destabilizing their overall illness. The risk of that can be mitigated somewhat by having either an antipsychotic or a mood stabilizing drug on board. In other words, when you have that antipsychotic or mood stabilizer added to the antidepressant, you're allowing the antidepressant to bring them up to a euthymic state without then overshooting into the manic state. Sounds nice in theory, however, that is not always the case in practice. You can certainly get a number of treatment failures, either due to the antidepressant just not working for depression, or you are getting some treatment failures as a result of antidepressants going towards full-blown mania. So the bipolar depression mentioned, it tends to be the one of the most debilitating aspects of the illness, because over the lifespan you're in it for such a long time, tends to be very resistant to treatments as well. For mixed episodes, across the board, you see VALPROATE is a mainline therapy here. Really one of our top choices for mixed episodes, because VALPROATE has good evidence to support its treatment of acute episodes. The antipsychotics can be fairly prominent in the TIMA guidelines, the APA guidelines, as well as some of the Canadian guidelines. And again, combination therapy is the way to go as far as second line. Adding VALPROATE and a second-generation antipsychotic together, for example, can be endorsed in many of the guidelines listed. So the mixed episodes, it's going to resemble in a lot of ways the acute mania, in that go for monotherapy initially, but looking to add on that second agent from a different class in order to optimize it for those who require that second line. So with that, a few important pearls to understand treatment of bipolar disorder. Mood stabilizer treatment is considered a long-term proposition because of the chronicity and the recurrence rates of bipolar disorder. You really need to get your patients to kind of stick to that treatment, and it's hard to do, obviously, if they're non-adherent due to side effects or having tolerability issues. So as healthcare providers, we really need to do what we can to design regimens that are as well tolerated as possible. If sedation's a problem, giving a big part of the dosage at bedtime and avoiding daytime sedation. If weight gain is an issue, obviously using drugs with a lower liability for weight gain and promoting dietary interventions. But the other issues around adherence is that you have to often educate the patients about the illness itself. Some people will say that they enjoy feeling manic. They do not want to come down off of that high that's associated with mania. The key educational point here is to remember that the behaviors and the impairment with mania can be so far and beyond not worth some of the pleasurable effects you get from it. The loss of judgment, some of the risk-taking behaviors, these sorts of things will often get people in trouble with their law, in trouble with their families, in trouble with their job. And this sort of existence can be very dangerous. So the educational piece obviously is to get patients to internalize that and to realize that the key thing to keep things on an even keel is to be adherent to their drug therapy. So psychoeducation and adherence counseling is going to be key for that. And the other important factor is to realize the risks around suicide. The reason that this is especially relevant because in the case of lithium, and to a lesser degree with some of these other drugs, the drugs themselves can be used in a suicide attempt. Lithium, again, can be toxic, and if not toxic, lethal in doses just above that used for our therapeutic use of lithium. So really at serum levels of twice or 2.5 times the therapeutic range, you can get into severe toxicity or even death in the cases of an intentional overdose. So you have to be aware of that and monitor for any sorts of signs of suicidality. So in conclusion, bipolar disorder is a chronic mental disorder that is marked by recurrent mood episodes of depression, hypomania, and or mania. The causes of bipolar disorder are multifactorial. Genetics play a role, as well as psychosocial stress, traumatic injury, and neurophysiologic changes. Mood-stabilizing drugs, including lithium, anticonvulsants, as well as the second-generation antipsychotics, really make up our armamentarium of pharmacologic therapies. And healthcare professionals must promote adherence by designing drug regimens to minimize adverse effects and by educating patients and families on the consequences of an untreated bipolar disorder. And by doing that, you can go a long way into optimizing overall outcomes for patients with bipolar disorder. So hopefully with this education, everyone is better equipped to understand the basis of this illness, design appropriate treatment regimens, as well as provide education to patient and families.